Revision total knee replacement can feel daunting for patients who are already frustrated with pain, stiffness, or an unstable knee from the first surgery. Thank you, Dr. Ebert, for being here. Can you explain exactly what is a revision total knee replacement?
Thank you. Revision total knee replacement is a complex procedure that involves a correction of a failed knee for either loosening or a failure of the components itself, such as wearing out of the components, or an instability of the knee. There's also a fourth reason a component will be revised, and that involves infection. But for this discussion today, we won't talk about the situation where we're dealing specifically with infection. Typically, in the knee replacement, the first step is the exposure of the knee. The exposure of the knee is very similar to that with a first-time surgery. Sometimes the incision needs to be a little longer, and typically we use the same incision so that there is not a second incision made. Making a second incision around a knee replacement creates deep concerns for wound problems, and that is something we do not want to have.
So, what do you do once the knee is exposed?
Once the knee is exposed, I'll specifically look at the interfaces between the femur and the prosthetic component on the femur. You can see in the drawing there is space between the femoral component and the femur bone itself, and that space should not be there. So there should be a connection between the implant and the bone, and that constitutes loosening of the femur. On the tibial side, same thing. If we see space between the tibial component and the bone, it constitutes loosening of the component, and that should not exist. Loosening of the component will produce pain and the swelling that the knee has when we identify a failed component. It's important to understand as well that one component could be loose or both components could be loose. In the situation where only one component is loose, sometimes only one component needs to be revised. If both components are loose, clearly both need to be revised.
So, how are the old implants removed?
Once the implants are identified to be loose, then we use a number of instruments, which involve small chisels, which are called osteotomes, that go at the interface between the implant and the bone. And we do that on the femoral side. You can see in the drawing that there is the small chisel that's being inserted at the interface between the femoral component and the tibial component. We also have saws that we use. On the tibial side, you can see, again, the small chisels being used. There's a high-speed burr that we use. There's also oscillating saws that we use. But these will allow us to remove the components safely so that we minimize any bone deficiencies.
So, what happens after the implants are removed?
Sometimes when the implants are removed, there are bone deficiencies. And these bone deficiencies can be relatively small, which are really of no consequence, or they can be larger bone deficiencies. We developed artificial bone, and on the table here I have some examples of the artificial bone. They come in various shapes and sizes. This is for the femoral component, and it has the same characteristics of bone, and bone loves this type of material. And bone will grow into this material and make it part of you. So on the femoral side, if we have a big deficiency, we'll use something like this. If we have a smaller deficiency, we use something like this, which will help to restore the areas where the bone is removed or gone. On the tibial side, we'll have a larger area that we can restore the tibial component utilizing something like this. Again, this is artificial bone. It's called trabecular metal. And also on the tibia, we have smaller ones that we can use. And they come in various shapes and sizes, and we use them liberally within revision surgery to allow us to reconstruct the femur and the tibia.
So how do you prepare for the new implants?
The new implants generally are fixed to the bone utilizing stems. This is a femoral component, and normally we will shape the canal of the femur seen on the drawing, and with the shaping of the canal, we will take a stem and we will insert that into the component, and this then becomes the new component which we utilize for the revision femur. On the tibial side, we have a very similar technique. The tibial canal is generally smaller, and we will shape the canal to accept a stem, and then the tibial component and the stem component are fixed together so that they provide the stability that you like for the revision knee replacement.
So how do you know that the new knee will fit correctly?
Once we've assembled the femoral component and the tibial component, there is a new plastic bearing which we then attach to the tibial component, and we take it through a trial of range of motion to determine whether or not it's stable and determine whether or not it has appropriate stability. And this trial is extremely important in determining the success of the final construct.
So what happens once everything looks correct?
Once everything is correct, the true components are selected and the sterile components are opened onto the back table and assembled, much as this femoral component would be assembled, and the tibial component is assembled. And you can see on the drawing how the components are then seated into the canal and usually cemented in place.
So what's the final step?
Once the final step is present, the closure is done. The components are cemented in place. Closure is done typically with stitches underneath the skin. And again, the same incision is used to avoid wound complications.
Well, thank you for breaking down such a complex topic in a way patients can understand. Before we wrap up, is there one key piece of advice you'd like every patient considering revision total knee replacement to remember?
I think going through this, you have to understand that this procedure is complex. It involves a number of different facets in terms to reconstruct the knee once the deficiencies are identified and once the reason for loosening has been identified. It has to be an evaluative process that goes through step by step each aspect of what we talked about today. And if that's done correctly, it can be extremely successful.
Well, thank you so much for sharing your expertise on revision total knee replacement today, Dr. Ebert. I know this will really help patients who are worried about a second surgery feel more informed and prepared.
You're welcome. Thank you very much.